Hello, this is Dr. Edward Halperin, and welcome back. It's number 27 in our webinars on the internet. 90 Minutes, the medical magazine of the web, is on the air, where we present a group of relevant presentations by experts, largely in response to what you've asked to learn about in medicine, healthcare, and health policy. As usual, we got some old friends and we got some new friends for you today. I've invited the Dean of the School of Osteopathic Medicine in Vallejo, California, Touro College of Osteopathic Medicine, Dr. Tami Hendriksz, because it's September and some of you parents want to know, should I let my kid go out for the middle school or the high school football team? Dr. Hendriksz is a pediatrician, and I framed the question, you've been our pediatrician for years. What do you think, doctor? Should I let my child go out for the middle school or high school football team? Next, it's fan favorite, Dr. Marisa Montecalvo is back. The incidence of COVID is up again. There's been discussions about yet another vaccine. So Dr. Montecalvo is going to tell us what's new about the COVID vaccine boosters and when we should get them and what we should be watching for. Our next speaker is someone who's going to be new to our audience. It's Dr. Daniel Zelazny, and he's going to talk about my shoulder hurts. He's going to tell us all about rotator cuff injuries and what should be done about them. It's a common problem. I'm sure many of you listening have had them, and he's going to give us an update about what these really are and what ought to be done with them. We're going to then wrap up our presentations with a panel discussion. I've invited Dr. Etienne and Dr. Karen Murray to join us, because there's been a lot of discussion after a recent Supreme Court decision about allegations of racial disparities in healthcare outcomes and disease incidents. So we're going to have some experts have a conversation about that. As always, if you have questions for our panelists, go ahead and type them into the Q&A box on your screen. We'll get to as many of them as we can during the Q&A part of our program after our formal presentations. For those of you looking for CME credit, you can get CME credit in one of two ways. You can call the number listed on the slide, and you can text the number listed on your slide, and in your text message, put in 55 HEME, H-E-M-E, all in capitals, and you'll get a response back by text message telling you how to fill out your satisfaction questionnaire and how to get your CME certificate. Also, if you don't like that technique, you can get out your handheld device and scan that QR code, and you'll be automatically taken to the website where you'll go ahead and fill out your satisfaction questionnaire, and you'll get your CME certificate. Whichever way you choose to do it, please go about doing it, because it's going to expire on September 12th at 12:30. And thanks for joining us, and let's get started with our program.
Hello, my name is Dr. Tami Hendriksz, and I'm the Dean at Touro University, California, College of Osteopathic Medicine, and a pediatrician. I'm here to talk to you today about understanding the risks of concussions in middle and high school football. I have nothing to disclose for this presentation. We're going to start with a question. Doctor, you've been our pediatrician for years. After what I've read about concussions, do you think I should allow my son to go out for the middle school or high school football team? This is an excellent question, and definitely one that pediatricians field on a regular basis. It's also one that has to be made by the family. It's a decision that the family needs to make after they learn all of the risks involved and how they can mitigate some of those risks. Then they can move on and decide what the right decision is for their child and for their family. So let's begin by talking about some of the statistics. As we look at youth football and concussion statistics, football has the highest number of sports-related concussions and other traumatic brain injuries among youth. Youth tackle football athletes had an average of about 7 head impacts during practice. So that's every single practice. They have about 7 head impacts and 13 impacts during a game. When we compare the statistics between tackle football and flag football, the median number of head impacts per athlete in a season for tackle football is 378, versus for flag football, it's 8, a total of 8 per season. So it's important for us to understand what it means when you have these repetitive head impacts over and over again, especially at a young age. We'll start by talking about some definitions. What is a concussion? A concussion is a type of traumatic brain injury that's caused by a bump, blow, or jolt to the head, or a hit to the body that causes the head and brain to move quickly back and forth. This fast movement can cause the brain to bounce around or twist in the skull, creating chemical changes and sometimes stretching and damaging brain cells. What is a repetitive head impact? It's when an athlete gets more than 1 head impact while playing a sport. What is chronic traumatic encephalopathy, or CTE? CTE is a progressive degenerative disease of the brain found in athletes and others with a history of repetitive brain trauma. CTE really came up in the news a few years ago when it was discovered how many professional football players have this progressive degenerative disease that, if left untreated, can lead to permanent brain damage. So we know that youth tackle football players have a really high chance of developing concussions. What are some of the consequences of concussions? If we're looking just in the immediate short term, so within the first few weeks after a concussion, they can have headaches, nausea, vomiting, visual problems, balance issues, moodiness, anxiety, irritability, sleep issues, including difficulty falling asleep and either sleeping for too long or not sleeping for enough, mental fogginess, poor concentration, and fatigue. As we look at long-term consequences of concussions, they mirror these, but they become chronic concerns. So individuals may experience chronic disorders of smell and taste, chronic mood disorders, including depression and anxiety, sleep disturbances, so continued episodes of either being too sleepy or not being able to sleep at all, developing that CTE that we discussed, cognitive impairment, and memory problems. There was a study that came out from Boston University that found that CTE was in nearly 92% of the ex-NFL players that had been studied. So it is incredibly prevalent. If you think these professional football players, they've probably been sustaining those repeated head injuries since they were children, right? Since these youth football games that we're talking about now. It's really important to recognize the signs of a concussion, because certainly one of the things that we found out is that if somebody returns to play and gets another head injury before they fully recovered from a concussion, that causes more permanent damage. The risk of permanent damage is greater. So it's important we can recognize the signs of a concussion so we can make sure that we pull the child out of play and keep them safe until they're fully healed. The most common signs and symptoms, and these do vary from person to person and the type and extent of injury, but the most common are headache, nausea, dizziness, irritability or crying, trouble concentrating, and sleep disturbances. Concussions are not diagnosed with imaging. It's really important to have people that are trained in recognizing the signs and symptoms of concussion. The players themselves need to have self-awareness and training, and coaches and teammates need to be trained to recognize symptoms so that everybody can help keep each individual member of the team safe. The CDC, Center for Disease Control, they have a fantastic online training program specifically for the youth sports coaches and for parents that can take, so you can learn more about what concussion, what types of injuries cause concussion, what concussion symptoms are. They have some online materials for the players themselves as well. As we look into preventative measures and protective equipment, so if your child really still wants to do tackle football, it's important that you learn the youth concussion laws in your state. While all states now have laws designed to reduce the risk of concussion and other head injuries in youth football, not all states' laws are equal, according to USA Football. Fewer than half have all the key principles like limits on full contact practices, mandatory education about concussion symptoms for coaches, removal of players from a game when a head injury is suspected, and written medical clearance for return to play. All of those situations help to keep the children safe. We want to highlight any rule changes that prioritize player safety. So research presented at the American Academy of Pediatrics recent meeting showed that limits on full contact practice, as well as teaching heads-up tackling, work to reduce concussion risk in football. Those proper tackling techniques are huge, emphasizing techniques that really minimize the head-to-head contact when most of these head injuries are occurring. Consider a baseline neurocognitive test. It's really helpful to do at the beginning of a season, and it can be repeated if there are signs of a concussion. It can help, along with medical evaluation, to make the diagnosis and to ensure that the person has fully returned to their baseline before they go back to practice. Making sure that your child is fitted properly with protective equipment, like a really good helmet, and wears it all the time, is hugely important. Helmets don't actually prevent concussions, but they do protect athletes from the most serious types of brain and head injury. And then following doctor's orders to the T if your child does have a concussion, really following those return to play protocols. So how do you keep your child safe? Offer non-contact or flag football programs. I recommend for all of my patients to remain in flag football at least until age 14, if not indefinitely. Limit contact during practices. Remember that tackle athletes have 15 times more head impacts during a practice or a game than flag football practices, but even those practice impacts really help, really can add up to causing continued damage. You want to make an effort to have certified athletic trainers available at games and practices who can recognize those signs and symptoms of concussions, who know what to look for as they're watching plays and tackles, and enforce rules for fair play, safety, and sportsmanship. Create a culture of safety. Foster a culture that values reporting and addressing head injuries promptly. Educate coaches, parents, and athletes about concussive risks and safety measures, and empower everyone to prioritize player well-being over game outcomes. By creating a really safe sports culture, we can help all of the athletes to thrive. So in summary, you're asking yourself this question: do I allow my child to go out for middle school or high school football, especially tackle football? It's important that you are aware of the significant risks with youth tackle football. The safest response is to keep your child in sports that have less risk of head injury. If your child's very motivated to play tackle football, then it's important that you're aware of the risks and it can help to ensure that your child will be as safe as possible. Thank you so much.
Good afternoon. I'm Marisa Montecalvo, and I'm speaking on the COVID vaccine yet again. Who will need the vaccine? I have no conflicts of interest to disclose. The learning objectives of this talk are to simply try to understand the current options for vaccination, the efficacy as we know it, and to discuss how variants affect decisions for upcoming vaccination. So I always like to start with a review of where we're at, and I want to emphasize that this is focused on non-immunosuppressed adults, because from shortly after vaccine authorization, it was clear that severely immunosuppressed persons, such as persons with cancer on chemotherapy or organ transplant recipients, would need a different vaccination schedule. So for non-immunosuppressed adults, as you know, primary vaccination started almost 3 years ago with the authorization of the 2 messenger RNA vaccines, followed by the vector vaccine. It quickly became clear that there was preference for messenger RNA based upon efficacy and the side effects of the vector vaccine. A year ago, The protein subunit vaccine was authorized. This was the 4th vaccine in the United States. And then last April, we moved toward use of the bivalent vaccine, something that had been developed as a booster to actually be used for primary vaccine. Regarding boosters, shortly after the authorization of the messenger RNA vaccines, although their efficacy was very high, it was clear there were breakthrough infections, and by the fall of 21, boosters were recommended for those at high risk. This moved to all persons ages 18 years of older by December with the onset of the Omicron variant, and then a second booster for those who are over 50 if they were in a situation where they thought their risk was high. Last year, the booster became a bivalent vaccine, which had both the ancestral strain as well as a strain against Omicron, and even consideration for a second bivalent if you thought you were at high risk. What's going to happen this year? We are waiting to hear, but ACIP is meeting next week, so we should have information very shortly. So again, just to summarize, as of April this year for primary vaccination, the only vaccines are the bivalent vaccine, the messenger RNA bivalent, or the protein subunit vaccine. The old vaccines are no longer available. Boosting is with the bivalent. You can use a protein subunit vaccine for boosting, but it's not so clear what its efficacy is against upcoming and current variants. All right, let's take a moment at efficacy. So if we look at hospitalization and critical illness, and the orange dot is the non-boosted, and these are recipients of bivalent boosters, you can see that clearly the booster does very well in the first 2 months after receipt, and then efficacy decreases, although more so for hospitalization than for critical illness. So you might be saying to yourself, well, wait a second, all these vaccines, right? Many of us have 4 or 5 vaccines on board. Then there's also been natural infection. Why do we still need all of this? Where are we at? So this graph from CDC shows a little bit of what we know about immunity in the United States. So this is taken from blood donors. And in a study of over 70,000 blood donors, they tested for both vaccine antibodies as well as infection-induced antibodies. Green is no immunity, and blue is combined infection and vaccine immunity. And although these data are already almost a year old, you can see how hybrid or vaccine and infection-induced immunity is almost at 50%. For the population tested. So again, you say, why do I need a booster? Well, there are a few other points I want to make before we get into that, which is the benefit of natural immunity also is likely more than what can be measured from a blood test. There are memory cells in your immune system, which are important contributors. And there are data now beginning to come out that natural infection may also give some mucosal immunity, which is at the site of infection. And that would be very good in terms of preventing infection. But these are all early data. So compared with protection from infection alone or vaccination alone, it does appear that the best protection against severe disease is hybrid immunity. But the problem is all of this works best when the protection is from an infecting variant that matches what you received either with the vaccine or when you had your infection. So let's take a look at variants. Basically, we know that the more mutations, the more potential that there is for immune escape, whether it be from natural infection or from a vaccine. So if we just take a look at this a moment, right? We start with the ancestral strain. Then you have Delta in the summer of 21, Omicron at the end of 21, which was so prevalent that it led to the development of a bivalent vaccine, a vaccine that would have both the ancestral strain and Omicron targeted, used in its development. So here is Omicron, but now we have all these other variants. So FDA met in June, and they had advised that this year's fall vaccine be targeted against XBB. And as you can see here, these are surveillance data from CDC looking at variant proportions in the United States from clinical specimens. And you can see in June, XBB was quite prominent. Now that has changed, but it doesn't mean that a vaccine against XBB won't be efficacious, because there's a lot of crossover. So it's all about how well a vaccine matches the strain in circulation. And just to let you know, there is another strain being looked at, which isn't even on this graph, which is BA 2.86. So where are we at? Well, as I mentioned in June, FDA said based on the totality of evidence presented, they advised manufacturers to develop updated vaccines with a monovalent XBB 1.5 composition. More information next week. So I just want to conclude by saying, please remember that it's not just about SARS-CoV-2. There are plenty of other respiratory viruses out there, and 2 of them are vaccine preventable. So influenza virus, as you know, the vaccine is recommended for all persons 6 months of age and older. It's a quadrivalent vaccine, 2 strains of influenza A, 2 strains of B. And how do they decide? They decide based upon what's the infecting strains in circulation, and that helps determine the composition of next year's vaccine. We also this year have a vaccine that is first available for adults against respiratory syncytial virus. Respiratory syncytial virus is a virus that has been a problem for little children and babies, particularly those with bronchiolitis and lung disease, but also is a prominent cause of lower respiratory tract infection in adults with underlying lung disease. And so a vaccine was first approved this May. It is for persons ages 60 and over, but it is based upon a discussion with your physician. It's not recommended for everyone, but really based upon what your underlying diseases are and what your potential risk and exposure may be. So in conclusion, where are we at with COVID? Given the efficacy clearly wanes and that variants will continue, and the true clinical impact of a variant is unknown until there are clinical surveillance data, it's very likely that we're going to need ongoing annual boosters, and that will be for all adults. This year, it appears it will be XBB 1.5, but we will learn more next week. I do want to mention that for those who can't take a messenger RNA booster, it is still recommended to proceed with the protein subunit as a booster, because there's always the potential of boosting, of some boosting having effectiveness. The approach to SARS-CoV-2 protection is clearly becoming more similar to that of influenza vaccination. And as we move into the winter season, protection against all 3 viruses may be needed. Thank you.
Hello again, this is your host, Dr. Edward Halperin, offering you the opportunity to give back to New York Medical College programs like the one you're watching right now, and our research programs take time, effort, and money. We don't charge for the CME credit. We don't charge a registration fee for these webinars. We rely on philanthropic support to keep these programs on the air. Great things are happening in New York Medical College. We hope you'll be a part of it. There are 3 ways to make a donation to support this webinar or support our research programs at the college. If you dial 914-594-2720, a real human being during business hours will answer the phone and be happy to take your credit card information. If you want to make a donation online, go to www.nymc.edu/give and give your credit card information online. Or if you like good old-fashioned ink and paper, you can write us a check, make it out to New York Medical College, put on the note line in the lower left-hand corner of the check that you're supporting our webinars, and put in an envelope with a stamp to the New York Medical College Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us and for supporting these webinars, and let's get back to our program.
Hello, everyone. My name is Dr. Dan Zelazny, and I'm an orthopedic sports medicine and trauma specialist here at New York Medical College. I've been tasked to give a lecture regarding shoulder pain entitled, "Why Does My Shoulder Hurt? Rotator Cuff Pathology." I also happen to be the head team physician at Marist College, and I deal with a lot of student athletes dealing with vast other sports medicine related injuries. Of course, the obligatory "I have no conflict of interest" slide is present. So I'll just jump right in by saying that shoulder pain is a very common entity, and the most common of which is a rotator cuff tendon problem, and it certainly is the most common tendon injury in all adults. 30% of adults over age 60 have a rotator cuff tear of some kind, and 62% of adults over age 80 also have tears. There are other similar symptoms that go along with shoulder pain. On the spectrum of rotator cuff injury, there's bursitis, which is not really a rotator cuff problem per se, but a problem that can be associated with the tendon, and of course tendinitis, or more accurately called tendinosis. And then there's partial tears as well as full thickness tears. The illustration on the screen actually shows the bursa, which is that bluish structure just underneath the collarbone and above the humerus, which is also kind of where the rotator cuff tendon is located. So they're intimately associated with one another. If you have shoulder problems with a rotator cuff, you're in good company. A number of celebrity athletes, including Drew Brees, famous NFL quarterback for the Saints, had an injury in 2005, had a rotator cuff repair, and was able to start the first game of the following season in 2006. Just some other ones, Serena Williams also had it, Clayton Kershaw from Major League Baseball, Paul George from the NBA, and for those of you who don't know, on the top right of the screen is Bobby Clark. He didn't really have a shoulder problem, but I'm a hockey player, and I would be remiss to not show an athlete. He's just famous for his smile. Well, what causes rotator cuff problems? Well, typically it can be an injury, of course, but it more commonly for most lay people is a gradual degeneration. It can occur after repeated activities, such as overhead workers, or like a painter or a carpenter. Tennis players get it, baseball athletes get it, like overhead throwing athletes. You can have bone spurs that occur that can impinge upon the rotator cuff tendon, which is just below it. That's what the illustration on the bottom right is showing. Again, the blue is the bursa. Just above the blue is the acromion process of the scapula. And if you have a little bone spur growing on the undersurface of that, it can impinge on the subjacent tendon, which is illustrated in the red there on the right, causing some problems. I mentioned age as a cause, but it's really actually a risk factor, and it really just follows up on the earlier statistic that a large percentage of patients will have tears, whether symptomatic or not, just based on their age. Some of the symptoms that patients have are a dull ache. They will have pain when lifting the hand or arm into certain positions, such as combing your hair, closing the car door, getting dishes out of the cabinet, but it can really be anything. Also, a lot of patients will complain of pain that disturbs their sleep when lying on the affected side, and they may also have pain with some associated weakness. By the virtue of anatomy, just as a refresher, the rotator cuff tendons are four, collectively known as the rotator cuff, the supra and infraspinatus, the subscapularis, and the teres minor. The most commonly involved one is the supraspinatus, again illustrated there, just underneath the clavicle and the acromion. This illustration just shows a simple rendering of a rotator cuff tear of the supraspinatus. And remember, these tears can be partial thickness, full thickness, or just some tendinopathy with tendinitis. Here's another picture of same. On physical exam, we will see in the office many different things, but here is one of them. It's called the drop arm test, which is in the picture. The patient will lift up their arm, or the examiner will lift up the arm for the patient actually, and the patient will not be able to sustain it in that position. The arm kind of drops, hence the name drop arm test. There are many others that have been mentioned over the years. There's the empty can test, there's the external rotation lag sign, belly press. They're all similar tests to address specific tendons of the rotator cuff. Like the empty can is for the supraspinatus, the belly press is for the subscapularis. We often get x-rays on patients that do come into the office, and they're often normal because, again, this is not really a bone problem, it's a tendon problem, and you don't see tendons on x-ray. So other imaging modalities are used, such as ultrasound, which is on the top right. But for me, and probably for most specialists, the MRI is much more illustrative, as it can show, obviously, the rotator cuff itself, but it shows other shoulder anatomic structures such as the labrum. It shows the bone as well. It can show other ligaments. So you get a lot more information probably from MRI. And also, ultrasounds are, technician dependent. You also need a good radiologist to read it appropriately. Historically, orthopedically, we always looked at MRIs, so we've become relatively facile at looking at a shoulder MRI on our own to determine, if there's a rotator cuff problem. But I would have a hard time looking at an ultrasound and figuring it out. So we need our radiology colleagues to assist us. The treatment for rotator cuff really depends on several things. One is age and functional demands. Other things such as the chronicity of the injury. Is it acute, which is usually we talk about less than 2 to 3 months, or is it chronic? Hand dominance sometimes plays a role into it. But the most important factor really is symptoms. If you're having symptoms, then we can and should do something, which we'll talk about in a second. But if you're asymptomatic and you just happen to find out that you had a rotator cuff tear because there was an MRI obtained for some other reason, that doesn't mean we have to do anything for it. If it doesn't bother you, there's no real reason to treat it. But of course, most people come to the office because they're complaining of shoulder pain, and there are several things that can be done. Usually, we manage these initially without surgery, and the American Academy of Orthopedic Surgeons recommendation is non-surgical management, almost always appropriate at the outset, and we usually prescribe a 6 to 8 week course of therapy at the outset. Sometimes that's continued, especially if the patient begins to experience improved function and a decrease in their pain. And we really limit surgical intervention for those patients that remain symptomatic despite non-surgical treatment. So in addition to non-surgical treatment with physical therapy, there's over-the-counter medications, anti-inflammatory medications, topical analgesics, and activity modification, things like that. Also, corticosteroid injection we often employ as an adjunct to non-operative management. But for those that fail all those modalities, we talk about surgery. Typically, the surgery is arthroscopic these days. Historically, we did them, and I have it in quotation marks, an open procedure, which is basically make a traditional incision but I would say that that's rarely done anymore, and most of these are done arthroscopically, which with minimal, less than about a centimeter incisions, like 2 or 3 of them, and we do everything internally. The illustration on the right, on the bottom right, is showing how we do it arthroscopically with little suture anchor devices that are implanted into the bone that have sutures attached to them, and we basically sew up the repair. That's what that green and white sutured X, or I guess it's a letter M kind of, is showing. Here, there are also surgical debridement and partial repair. We kind of reserve those for patients who have chronic massive tears with a lot of muscle atrophy and retraction that we can't really get the torn edge of the tendon back to its bony insertion. So sometimes we even employ a patch. That's what the top right is showing, or even a muscle transfer. And then in most extreme cases, we talk about arthroplasty for tears that are not repairable, and for patients that have painful pseudoparalysis or some level of glenohumeral arthritis or shoulder arthritis, where the rotator cuff repair has now become the secondary problem and the arthritis is really the primary problem. What's depicted here on this X-ray is a reverse total shoulder replacement. It's being done much more commonly than in years past, and has shown to be a very powerful tool in our armamentarium to treat these problems. Again, the non-surgical management I already mentioned: activity modification, medications, creams, turmeric, which is a root, has been shown to have some significant anti-inflammatory properties, which help patients with any inflammatory situation, even if it's just arthritis. Physical therapy, as I mentioned, along with modalities such as ultrasound and electric stimulation, are also useful. As I mentioned, it's a several-month course, and corticosteroid injection. Here is a intraoperative photograph of an arthroscopic procedure. I'm just showing the biceps tendon. Just to the right of that is the portion of the supraspinatus tendon, the other white structure. It's an ambulatory same-day procedure. The patients are discharged with a bandage in their arm and a sling. They still undergo physical therapy, of course, after the surgery, and you'll see a gradual return to activities, unrestricted activities, usually in about 3 to 6 months, depending on the patient and the injury. Post arthroscopic surgical repair, the patients do very well. Most of them will return to their baseline level of function. Even elite athletes, as I mentioned at the outset of the talk, are able to return to their prior level of competition. And with that, my talk is concluded. Thank you very much.
Hi again, this is your host, Dr. Edward Halperin. For those of you looking for continuing medical education credit for today's webinar, you've got 2 ways of doing it. You can send a text message to 828-295-1144 with the code 55HEME, 55HEME, all in capitals. If you do that, you'll get a text message response with instructions as to how to fill out your satisfaction questionnaire for today's webinar and how to get your CME certificate. Another choice is to take one of your handheld devices and scan the QR code in the right-hand side of the screen, and it will automatically take you to the website. It'll then take you through the satisfaction questionnaire and get your CME credit. However you choose to do it, please remember to do it by Tuesday, September 12th at 12:30, because after that, the code will expire. I suggest you take a screenshot, write the number down, take your cell phone out and take a picture of the screen so you have the information to get your CME credit. Remember, if you have any questions for our panelists, type them into the Q&A box on the bottom of the screen. We'll get to as many as we can during the Q&A part of our program. And let's get back to our program. Hello again, this is your host, Dr. Edward Halperin. I'm going to serve now as the moderator for a panel discussion about a topic that for many Americans is troublesome and much in the news. You'll remember that a few weeks ago, the United States Supreme Court issued a 6-3 decision in 2 cases involving selective higher education admission. They were called the Students for Fair Admission versus Harvard and Students for Fair Admission versus the University of North Carolina at Chapel Hill. By these 6-3 decisions, the court largely, but not completely, overturned decades of affirmative action in selective higher education admission. Tucked into the dissent of the 3 judges who dissented is a dissent by Justice Ketanji Brown Jackson. She writes in her dissent, "For high-risk Black newborns, having a Black physician more than doubles the likelihood that the baby will live and not die." This quote is used by her to bolster the argument that we ought to have a healthcare workforce that reflects, to some extent, the racial distribution of the population. She has a footnote to that statement, and if you look up her reference, it's a paper in the Proceedings of the National Academy of Sciences, August 17, 2020, by B.N. Greenwood et al. The paper is titled Physician-Patient Racial Concordance and Disparities in Birthing Mortality for Newborns. In this paper, the authors assert that there is a mortality difference for Black newborns taken care of by Black physicians versus Black newborns taken care of by white physicians. A key sentence is, Black newborns experience 430 more fatalities per 100 births than white newborns under the care of Black physicians. The mortality penalty for Black newborns is only 173 fatalities per 100,000 births above white newborns, a difference of 257 deaths per 100,000 births, and a 58% reduction in the racial mortality difference. That's where the Supreme Court judge got the phrase, more than doubles the likelihood the baby will live and not die. The story of alleged disparities in disease incidence and disease morbidity and mortality between the races, however, is far bigger than simply talking about newborns. It goes into multiple diseases. In the last week or two, as I was getting ready for this panel discussion, I started tearing articles out of my oncology journals on the topic. Racial disparities in cancer mortality for patients after Medicaid expansion. The more Medicaid was expanded, the less the discrepancies in cancer mortality in gastrointestinal malignancies. Racial differences in prostate cancer with MRI-guided biopsy. Black men less likely to get an MRI and may be missing anterior prostate malignancies. The morbidity and mortality rate for carcinoma of the cervix and breast cancer and colon cancer different for races, cardiac disease different. So in our panel discussion today, we're going to talk about this topic in general and the issue of, did the Supreme Court judge correctly quote the literature in specific? Got 2 panelists to talk about this important topic. I'm going to ask them to introduce themselves to you in alphabetical order. We'll start with Dr. Etienne, please.
Good afternoon. Thank you very much for having me here, Dr. Halperin. And I'm Dr. Etienne. I'm a neurologist specializing in epilepsy and brain injury medicine. And I'm also Vice Chancellor for Diversity and Inclusion here at New York Medical College.
Thank you. Dr. Murray.
Good afternoon. My name is Karen Murray, and I'm an OBGYN, general OBGYN, and the Dean of Admissions here at New York Medical College. Thank you for having me.
Thank you also for joining me, Dr. Murray. Dr. Etienne, you're the card-carrying epidemiologist of the group. You're the one with the master's degree in epidemiology. So let's talk about the big picture first. What do you think are the most striking examples whichever disease you choose, about the issue of whether there are racial disparities in the United States in disease incidence and outcome.
Yeah, so thank you very much for asking that question, Dr. Halperin. First, I'll comment on Justice Ketanji Brown Jackson's statements that you've made. She referred to babies that actually had access to physicians, whether they were white or Black. One of the, which is a tremendous issue here, the high infant mortality rates. I'm going to talk about people who don't even get access to see the physician, which in my field, neurology, we've studied. And what's been found is that Black patients are 30% less likely to see an outpatient neurologist, and Hispanic patients are 40% less likely to see an outpatient neurologist. So that's not even getting your foot in the door to start arriving at a correct diagnosis. And a large part of that has to do with who is actually going to work in many of these underserved areas. And the data is very clear that patients who are historically marginalized are the ones who are most likely to go back and work in these underserved communities. So really, any effort that we see that limits those numbers or in any way decreases the number of Black and Hispanic physicians, which is already low to begin with, could actually threaten to even increase that gap in access to care.
Do you view this as a debate in which there are really two sides, or do you think it's a settled question, Mel, that there are these disparities?
Well, I think there is a debate. There are multiple sides. I would say it's the kind of thing where we do want to figure out what is the best way to gain access, to give access to care in these communities. One is somehow incentivizing people who, since you have a limited number of Black and Hispanic physicians, so how do we incentivize others from other groups to actually have that interest in going in to serve those communities? Now, as you cited in that paper, we found that when Black babies, and we see it also in cancer and other diseases. There was a study that came out just this week looking at who the patients trust for information regarding prostate cancer. And what they found was that the Black patients are more likely to trust physicians who are Black. So really, that's also going to be negatively impacting their access to diagnosis, access to treatment.
Okay, thank you. Dr. Murray, after the Supreme Court decision occurred, my email inbox exploded with people wanting to argue about this, acquaintances and people who share opinions. I don't believe the data. I've practiced medicine for years. I never saw this. Or there's patient selection, or the paper shouldn't have been published. I don't like the way they interpreted the data. This is really just a euphemism for who's the disproportionate number of attendings in the newborn ICU versus elsewhere. What's your take on Justice Jackson quoting this paper and the data, and how did you come down on it?
Thank you for the question, Dr. Halperin. I think the picture is a little bigger than Justice Jackson really divulged. There's a larger number of premature Black infants that are born. So the story starts before birth. It starts with prenatal care. There is a vast majority of women of Black descent who do not show up for prenatal care or who do not receive prenatal care at all. And so they have a disproportionate number of premature babies being born to women of Black descent. There's also the other part of that being that women of Black descent have a higher number of chronic diseases, and chronic disease does play a part in prematurity of birth as well as complications of the newborn. It's been shown that part of that reason is women of color or Black women very rarely bring their concerns to their physicians because they feel that their concerns are not usually I guess, taken as seriously. There was a study or a statement that was put out by the CDC on August 22nd, where they talked about 1 in 5 women stated that they didn't feel that their concerns were adequately addressed during their pregnancy. And so they just didn't bring it up. And for, they feel that either they were not heard, they felt like their privacy was not adhered to. And so these patients feel marginalized for the most part. And so for that reason, there's a distrust of the medical field. There's a distrust of bringing their concerns to their physicians as they don't think it's taken seriously. So I think that's the bigger picture. I think that when you have someone whose baby is born full term and they have care immediately, the outcomes are similar. When you look at the prematurity rate is higher in Blacks who give birth.
Let's dig a little bit into your comment about women who don't get adequate prenatal care.
Mhm.
I remember when I was dean of the medical school at the University of Louisville and presenting a study to me where they're going to give out vouchers to pregnant women if they show up for their prenatal care appointments to try to actually get them to go to the doctor. And I'm reading along saying, well, that's interesting. We're going to get a voucher for a package of diapers. You're going to get a voucher for baby formula, but they're giving out vouchers for fast food places also as an incentive to get a pregnant 20-year-old to come. And I'm thinking, I don't know whether that's a great idea. So talk to me about economic incentives, basically, paying people to show up for their prenatal appointments as a medical care strategy. What do you think about that?
I think that works to some extent, but there's an inherent mistrust of the system. And I think that giving someone a voucher for fast food only adds to the problem that is there to begin with, which is hypertension, diabetes, obesity. All those problems makes their pregnancy more high risk and, prones them to preterm delivery. So my personal opinion is I'm not for that particular type of enhancement per se. I think what women need is more outreach and more availability of services that's going to help them during their prenatal care to get them through to carrying to term. And I think that's where we're going to make the difference.
Thank you. Dr. Etienne, you mentioned the access of people to specialists. Can I get you to expand with some more examples, the studies about whether or not a Black patient's more or less likely to be taken care of by a cardiologist or get admitted to a cardiac service if they're having an MRI versus general medical service, or people with broken bones, access to pain meds. Can you give us some other examples of disparities that were discussed?
Yeah, absolutely. I mean, really, when you look at any field of medicine, we are seeing this disproportionate access, one, to the primary care. That's where it begins, because usually you need a referral to see these specialists. Then getting to the cardiologist, orthopedic, whoever it might be. Part of the issue, if you look at surgery, for example, a lot of times if a Black patient is going to have surgery, they're more likely going to be in one of these underserved areas, under-resourced hospitals, where you're going to have surgeons who are, because there's not as many of them, they're not going to be the super specialized surgeons a lot of the time. So there'll be surgeons who often will do multiple types of surgeries. So whereas if you go to a more specialized place, you might have a surgeon who, I only do cabbage and I only do this type of surgery. And so when you're not getting access to those types of surgeons, a lot of times you might have worse outcomes. Not to mention, after the discharge, after the surgery, we see disproportionate rates of getting rehabilitation. So we know after a cardiac surgery, after whatever surgery you've had, you need cardiac rehab, you need physical therapy and all these different types of things. If you're not getting that, this patient's already set up for failure. And you say, why did I do the surgery in the first place? If they're not going to get the appropriate aftercare that's actually needed. And then now they're going for repeat surgeries. And then it gets blamed on the patient. Well, you just didn't follow up. You just didn't do X, Y, Z. But in reality, the way the structure and the system has been is in place, the patient didn't really have that opportunity to have that success. So really, that's why getting more providers, more people who can actually provide this specialized care into those communities is so important. And really, you look at any specialty, whether it be orthopedics, whether it be open heart surgery, whether it be neurology, rheumatology, the numbers of Black physicians are so small in each of those, Hispanic physicians so small in each of those. And you have to go back through the pipeline and you say, if we try to get more neurologists, you're going to be taking away from another field because we don't have that pipeline in place. So really you have to go downstream and say, okay, how do we get more into college? Now we got to go to high school, go to the elementary schools and really start patching the holes in that pipeline so that you can actually have a good cohort of people coming in through the pipeline to get into these institutions and start actually getting the right number of specialists for these communities.
Thank you. Well, as usual,
and Dr. Halperin, the thing I'll add also is once you start getting those specialists in place in those communities, those same people end up being the role models for those same underserved children. So now they're seeing doctors and nurses and everybody, scientists and dentists who look like them and say, oh, wow. So I can actually, not like when I was in 5th grade and I said, I want to be a doctor. And my classmates' response was, there are no Black doctors. And because I hadn't seen one in real life, I started to believe it. And really, you shouldn't really have to grow up like that. And that really also puts people at a disadvantage. So really, we want to get those role models into those communities to show these young people what is actually possible for them, that there is a pathway to actually getting there. And with a pathway, that gives you hope for the future.
thank you. As usual, the time has flown by. I want to conclude with asking both of you, how would you have responded to an email I got from a white physician who, in essence, wrote, I practiced medicine in a large county hospital in the north for 40 years. I never saw any discrimination. I don't believe this kind of data. He went into specifics about the paper per se, but the essence of his argument was, I'm an eyewitness and I have not seen this. Well, let's start with Dr. Murray first, and then we'll give Dr. Etienne the last word.
Sure. Thank you, Dr. Halperin. I think what I'll do in order to answer that question, there was AAMC had published a article that was looking at, should a Black patient be treated by a Black physician? And in that article, they referenced a dermatologist who was of non-Black descent. And they were treating a patient who had some type of seborrheic psoriasis of the head. And she prescribed the medication and she told the patient, use this medication when you wash your hair. Now, because this physician does not know the culture, does not know, how the Black patient, takes care of their hair, she assumed that that person was going to wash their hair every single day. So when the patient showed up for a follow-up and the disease had not gotten any better, she was like, well, I thought you said you used the medication as prescribed. And the patient said, well, I did. I wash my hair once a week. So the doctor, not knowing that cultural care, somehow made her choice for treatment not effective for that patient. Now, had she been more specific, or had she known that in that culture they washed her hair once a week, she probably would not have prescribed that medication or chosen a different route. So it's not that there is overt discrimination. Sometimes there is, but it's not that there's overt discrimination, but it's just not knowing the nuances of someone's culture, someone's background, their way of life can ultimately really impact the kind of care you give.
Thank you. Dr. Etienne, as you offer your thoughts, I can't resist observing that Chief Justice John Roberts in his decision made it clear that Students for Fair Admissions does not apply to the military academies, that their mission is such and their need for diversity is such that this doesn't have to do with them. So as an officer in the Navy, both how would you respond to my questioner, and how come what's good for the goose is not good for the gander, the old cliche? Why is the military special in this conversation according to the special mission of the military according to the Supreme Court?
Yeah, I'll answer both questions. I think Karen did an excellent job of addressing that point. One thing I'll add to that, what that doctor's question is, you know, when I look around my hospital, I might say the same thing. I don't see any obvious racism or disparities in treatment. That's like saying, looking at a person and saying, well, I don't think that person has cancer. How do you know until you've actually studied it? So to actually know if this is happening at your hospital, you'd have to actually start saying, let me see the numbers and see what is happening, what are the outcomes, what are the differences? And we see consistently each time you say, let's stratify by race, let's stratify by gender, we see oftentimes stark differences in the way people are being treated and their outcomes. So that's how I would respond to that, is until you've studied it, you really don't know. And two, with regards to the military portion, really, back in the 1940s, President Harry Truman issued an executive order to desegregate the military. That's before Brown versus the Board of Education. That's years before that, because the U.S. military saw that this idea of separation was just not good. And that we really do need to be progressive, and we really do need to have an integrated armed forces. And the military sees the high value of having diverse officers, having diversity in our enlisted people, and that it makes the military stronger. And so really, I won't go into too much more details about that, just because I can't just speak freely about the military because I'm still in. But I would say that's the most basic thing, is that we know that there is strength in diversity. And if we were to, I could see, serious issues if that were not in place in the U.S. military. And I think the same we'll see in the field of medicine. If institutions aren't able to find really good ways to maintain diversity on their campuses.
I want to thank Dr. Murray and Dr. Etienne for chatting with me. We look forward to your questions and comments. Please type them into the Q&A box, and we'll get to as many of them as we can during the question and answer part of our program. Thanks to our panelists for a stimulating discussion. See you all at the Q&A.
Thank you.
Thank you.